So, uh, as Anton mentioned, I am a psychiatrist with Wayne State University and Wayne Health. I would say I'm mainly a hospital-based psychiatrist. I work on the medical floor, seeing psychiatric consults in the burn unit, the ICU, and the surgical floors, as well as the medical floors. I do some work in the crisis center, seeing psychiatric emergencies, and I also have some outpatient practice. Um, and I've actually met Dr. Babushkin as a resident when I was training here. So I stayed on after I finished my residency. And that's when I was exposed to the world of psychoanalysis and psychodynamics, and where I started studying a little bit and took some interest in borderline personality, which we'll discuss today. Um, Other than that, I'm from around here. I was raised here and went to school in Michigan, so I've kind of Michigander and Detroiter through and through, and it's just a pleasure to be here.
For sure. Thanks, Omar. Really appreciate it. It's great to have you. Bill, I don't know if you want to make any comments or kind of, please.
No, I'm work at Start My Wellness with Dr. Babushkin, and it's nice to meet everybody. I'm a licensed psychologist. I do clinical neuropsychology, which is psychological assessment, evaluation for a host of different issues, including borderline personality, but certainly other things as well. And I'm looking forward to participating. This is a very important topic.
For sure. And for those, we do this monthly podcast. We invite kind of our colleagues, sometimes from Michigan, like Dr. Soubani, sometimes from other places. And we Start My Wellness is a mental health company where we help people connect with healthcare providers in mental health. It could be a therapist, psychiatric medication, psychological and neuropsychological testing. I'm a therapist myself. I'm a psychoanalyst by training, and I also run the company. So this is kind of our way to connect with the community. And for people who are our guests, participants, again, everything is confidential. Nobody sees your name or anything about you. But if you have questions, which we hope you do, please put them into the chat. There's a Q&A function in this kind of webinar format on Zoom. And I'll see the question, I'll read it out loud, and hopefully Dr. Soubani, Dr. Bloom, myself, we can kind of include it. We would love to kind of hear your thoughts as the conversation goes on because well, this is mostly to be of use to you. Whether you're a mental health professional or a person who lives or in our community, we'd love to kind of hear what your thoughts are. We try to pick topics that are relevant. So, okay, now with that kind of brief introduction, maybe, I don't know, Dr. Shivani, if we could kind of start off with, can you give us kind of in your experience, both hospital, outpatient, what when you think of borderline personality disorder, it's a commonly used, a lot of people throw around, especially today, they kind of use that term. Sometimes professionals, I used to be in a case conference where somebody would say, that patient is a borderline. You'd say, like, what do you mean? Like, well, what are you referring to? What do you mean by that, right? Or sometimes like a non-mental health professional might say, oh, my uncle, blah, 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 or something like that. When you hear those words, can you describe what you think as a psychiatrist from your kind of experience? What does it mean to you? How do you understand? Just kind of broad terms.
Sure, sure. Now, I do agree with you that often patients who are, and people and family members and friends who are found to be difficult are often labeled as borderline personality. And sometimes celebrities have been labeled as borderline personality disorder patients. Um, Now, when I think of the term after a lot of training and a lot of reading and a lot of self-reminding, uh, I al- I think of it as a borderline personality organization. And I think why I'm hoping there's some maybe practitioners with us today because when we think about it this way, actually, it can help us visualize other patients and it extends to other people and with different struggles. Um,
Sure.
Now, uh, people with borderline personality often and most of the time have other psychiatric disorders and illnesses that are what we call axis one, meaning that they are um, neurochemical, biological, and psychiatric. The personality is the foundation where these illnesses and disorders rest on. Okay. And when we say something, a personality disorder, it's really talking to how they experience relationships and how they relate to others, in another way of saying it, and
Mm,
how they use defense mechanisms when they become stressed. And the one thing I'll say and I'll maybe throw it back to you, is the interesting thing is that when borderline personality, the origin of the name, it's an old psychiatric term. It's one of the first ones in the world of psychiatry. And it does come from the the concept that it's on the border between neurosis and psychosis. And what does that mean? It really means neurosis on one side is what we think of when we think of anxiety, obsessions, compulsions, depression. So people are overwhelmed by emotion, but their sense of reality is intact.
mm,
On the other end of it, there's psychosis. And I know, sometimes people think when they think of psychosis, they think of hallucination and delusions, which is definitely there, but it also includes a break in reality where our sense of reality is altered. People start to disassociate, people start to get suspicious, people start to lose a sense of themselves.
sure.
So borderline personalities really rests upon between those two things and can often oscillate between from one to the other and include both.
And so a person who kind of struggles with some of these difficulties, maybe sometimes they're able to have a good sense of reality, but sometimes they're not, depending on the stressors or kind of what's going on within them. Is that part of the idea?
Absolutely, absolutely. And overwhelming stress, stressful situations. And in my practice, I see this definitely when people are in the hospital
Hmm.
experiencing medical illnesses and medical emergencies. I'd like to say their want to use the word ego here, but
Hmm?
their sense of self quickly starts to deteriorate.
Sure.
And that can happen for a lot of different reasons, but they start to lose sense of reality, the insight into themselves, what's happening around them. Yes.
That's very interesting. Now, what about to kind of follow up on one thing you said about personality, right? Does that mean that somebody could have sort of a vulnerability to borderline type conditions? Like I'm assuming some of that's maybe genetic, biologically, maybe hereditary, right? There's some component like that. But would you say that it's also the case that how one navigates or manages or deals with those sort of borderline tendons, I don't know, possibilities is different, right? Some people might be more able or less able to manage those symptoms. Do you think is that accurate or?
Th that is an accurate thing. Now you did mention something important here, that there is a biological and a genetic component first, and that's where we kind of our story starts.
Yeah,
So most people with a family member with a borderline personality disorder, they do have a higher risk. There is some familial vulnerability.
sure,
Um, and if with siblings, it's the same thing. Now, there are some studies that looked at twins,
sure,
where one of the twins developed a borderline personality and the other did not. Okay, and that can be in the same household, and that can be if there was an adoption in place.
sure,
So that suggests that the environment has an equal effect in this picture.
for sure. That makes
Now,
sense.
yeah. Now the other thing is that there's also a lot of association with a lot of other mental illnesses. So, for example, particularly bipolar disorder.
Hmm,
Okay, so people with borderline personality often do have a bipolar illness. But the most important thing, and maybe where we can kind of, if you will allow me to push this discussion, is that without a doubt, the overwhelming majority of patients with borderline personality do have some form of a trauma-related disorder
hmm,
where they
okay.
had a severe trauma, especially early in their life.
I see.
And maybe you can speak better to me, better to us about what trauma means. It can mean a lot of different things.
Sure.
Um, but there was some disruption, especially in their formative years when their personality was kind of coming together, which caused a break in there.
That's so interesting that because that really speaks to kind of not only their genetics, but what was their life experience? Were there difficult, overwhelming, very hard to manage like I mean, there's extreme cases like war, right, or some kind of conflict like that, or extreme stressors in the family, but that's very interesting. So somebody may have the predisposition to maybe having some of these challenges, but if there are not as many overwhelming stressors, in their life, they may not kind of develop this sort of organization of their personality, right? They can kind of cope with things better despite their internal sort of vulnerabilities, right?
Absolutely. Absolutely. I would say that, and that can definitely mean physical neglect, emotional abuse, physical abuse, neglect, um, and of course, and the most tragic, I think, the sexual abuse.
For sure.
And I mean, comorbidity with post-traumatic stress is like it can be up to 70%. So I mean, it definitely is a uh, something that cannot be overlooked. Now, why I'm saying this is that there are treatments for PTSD,
Mm,
and that can help when you treat those symptoms and you calm those certain parts of the brain down. The
see,
rest of the personality can kind of be able to restart its growth.
see. That's very interesting and hopeful in a way, in a real way. One question, Omar, that we have from the audience here, I think is really interesting. This comes from a professional, a mental health professional. Um, so we're kind of started off here talking about why understanding borderline personality organization is important and valuable and kind of necessary, right? And we don't want to, what we want to guard against is the maybe overuse. We don't want to just like say anything is, plus it doesn't really say much. We could say, oh, that's a borderline, whatever, but that doesn't tell us much. You have to really investigate, as you're saying further. Was there a trauma history? Is there PTSD? What are other conditions kind of related under the umbrella? That's very helpful, I think. What about the possibility of under diagnosing this, for example. Like a clinician asks, sometimes you see a patient who has this kind of, let's say, personality features, organization. You don't want to stigmatize them, over-label them, say they're bad. We don't want to, but we also want to accurately capture some of what their difficulties are. How do you navigate that sort of tension between we don't want to just label people, but we also want to know, hey, how do we understand what's going? It could be helpful to understand what's going on, right?
Yes, absolutely. Now, as a clinician, I would say the most important thing is that we gather evidence and we build symptoms. Okay, that's if we're talking in pure medical jargon, but maybe we
Sure.
should have um, a discussion about what borderline personality disorder is all about.
Okay.
What we can talk about is, first of all, it's instability in emotions, relationships, self-image, and impulse control. Those are kind of the main
Sure.
buckets that we're going to be looking at. So, for example, people have a severe, well, maybe I could say this, they have a frantic effort to avoid abandonment. And that can be a real abandonment or that can be a perceived abandonment. They have a pattern of very intense and unstable relationships, and they go from idealizing that
Mm-hmm.
the person is amazing and this is the right one for me, or the best therapist I've ever had, or no one says about me the best psychiatrist, but they say he's the best psychiatrist. And then very quickly they say he is a bleep, or,
Sure.
fill in the blank.
Sure.
Then we can go on to identity disturbance, meaning their sense of self is not there.
Mm.
Some people feel, and this kind of relates to other things as far as disassociation, to stick with identity disturbance, um, they may have changes in their sexual orientation. They may have changes in where they live and what they do, and their interests very quickly.
Mm.
Okay? There's impulsivity, so the things that we all know as far as substance use, spending, binging,
Sure.
reckless driving, sexual impulsivity. The most concerning one, and something that we all have to be aware of, is that these folks are very prone and very at risk for suicide and
Mm.
self-harm. Now, suicide and self-harm can mean a lot of things, but what I want us to keep in mind is that it's in its nature may be a form of communication.
Okay.
Okay? We can talk about that, but I mean, even just the meaning behind action. A lot of these people have something called uh, alexithymia, which means having, well, Anton, do you know what that means? I'm sure you do.
Well, yeah, usually we use it to say a person's not able to articulate and know their emotions. They're kind of like detached from, don't have a good sense of how they feel. They can't kind of in a granular way, because of usually very difficult experiences, they can't kind of articulate what those feelings are, talk, manage them, right? Something like that.
Absolutely, yeah, absolutely. So it comes from, so to break down the word, it's called a, meaning without, lexi, meaning words, and thymia, which actually means the thymus right here in our throat. And back in the day, a long, long time ago, they used to think that feelings come from this gland right here.
I see.
So that's when we get emotional, we start tightening up right here.
Mm.
And also, you can you remember a time for that. So when people don't have words for how they feel, they act out.
Right.
Okay, so there's meaning behind the things that they do.
Sure.
All right. And then one of the more important ones, and maybe one that we can talk about, is this chronic feeling of emptiness.
Mm.
These folks can be in a room full of people and they may in fact be the center of attention. A lot of like what you see on TV, yet inside they have a sense of emptiness
Sure.
and they may feel lonely, unfulfilled, depressed. And
It's interesting, like when you're describing this, I think of how painful must it be to to kind of experience that, right? Like maybe for the person who's the recipient of their behavior or impulsivity or changes is very hard, very stressful, very like disorienting. But for them, the person who's, with this kind of condition, maybe they're in pain or they're really struggling and they're kind of giving voice to it, but just in a very, very sort of we think of as problematic way, right? I mean, if they could say, "Hey, Dr. Soubani, I feel upset right now, and I need your help to reassure me," well, that would be more helpful than, throwing something, so to speak, right?
sure, true, absolutely,
If
absolutely.
if I can interject
Yeah.
one thing at this point, this is really a very interesting discussion, and from an evaluation point of view, psychological testing evaluation point of view, one of the things that I see, particularly when I'm evaluating adolescents or teenagers, is that some of these same symptoms or problems are can be embedded in perhaps a more complicated adolescent developmental kind of framework that eventually resolve and don't go on to become a fully
Mm.
formed personality disorder.
Mm.
So when we're doing an evaluation or when we're trying to decide whether or not somebody truly has borderline features or is a borderline personality, it's important that we include the rule that it is a stable, fully formed part of the person's
Mm.
personality, and it
Yeah.
isn't a transient type of state as part of the development, which can sometimes happen.
That's very interesting.
Agreed. Agreed. There's a great book if there's any clinicians. I'm sure Dr. Bloom, you've heard of it, but it's called Treatment of the Borderline Adolescent by James
Mm.
Masterson.
Okay.
Yeah,
It's an old book, but it has great examples and great cases where exactly to speak to what you say is that the parts of the personality kind of reconstituted and developed development kind of went forward. It's a
sure.
really interesting book.
Yep.
And also, Omar, would you say to Bill's point, if you're, let's say, doing an evaluation for an adult, you're also probably thinking about what's the context, right? Like if something looks like borderline behavior, probably, there's an underlying condition, but if the person, let's say they just lost a family member or some horrific thing just happened, maybe we also think about what's the context of their life, like what's their age, life experience, history, right? I'm sure you would consider those factors.
Absolutely, absolutely. Now, in a lot of our work, I will say that we just see a slice of the patient or of the
Sure,
person.
for
Okay,
sure.
so we don't see longitudinally. Okay, so the longer that to answer the question from the chat is that um, I I don't think personally that a borderline personality diagnosis can be made within 1, 2, 5, 10 meetings or sessions. It can be thought about and it can be kind of explored, but it should be something that you come up naturally and kind of like organically
Mm,
as you know the patient and as you see um, and we'll talk a little bit about this, but defense mechanisms play out in front of you. I think that would be most helpful. And you can
yeah.
even point it out to the patient that I'm noticing that um, this is happening.
Mm.
Um,
Right, so you wouldn't kind of, not that the commenter wasn't saying this, but you wouldn't rush to, there's no need to, like on day one, say, oh, this is borderline. You say, okay, there are some symptoms here. Obviously, there's some difficulties. You get to know them, maybe offer treatment and help them. And over time, when you see these kind of shifts in emotion, reaction, behavior, impulsivity, the things you mentioned, then maybe you start to say, wow, I've seen this patient now for a year. There's kind of a chronic or ongoing or unresolved, or at least not yet currently resolved sort of stuff. Then you might say, wow, this is, that fits more into that umbrella, right?
Absolutely. Now, patients with borderline personality, they confuse us. Okay, they confuse us,
Hmm.
and we should keep in mind it's because they are confused. Okay, so uh, uh, they will come up with all kinds of reactions in you. They will bring all kinds of reactions in you. Now, what makes a good therapist in these cases, in these situations particularly, is someone
Hmm.
who has, and of course, you can, I think, speak to this much more than I can, but and from my view, is that someone who has good ego boundaries and good boundaries in general, and very strong mood regulation. Those two things I think are really important in these cases because, again, we become confused and we become reactive because the patient is this way.
For sure, there's some really interesting work I used to read about from Peter Fonagy in the UK about how working with borderline personality type of conditions, reflective functioning is so important. The ability to kind of step back. The patient struggles with stepping back and saying, "What am I feeling? Why am I feeling that? How am I dealing with it?" So the clinician, it kind of mostly is the one saying, "Whoa, whoa, let's pause here and reflect, right? We gotta step back and think about what's going on, not be so impulsive or overreactive."
Absolutely.
Um, Omar, I wanted to. I'm really curious about how I like how our conversation is developing. I just want to come back to one thing that I think may be of use to our listeners. Um, we're talking a lot very helpfully about what does the professional do or experience or think about, which is extremely useful. But I think one question kind of that's top of mind for our participants is, okay, let's say I'm a family member. I'm a parent, a spouse, or this is my parent that is acting this way, or my sibling. When and how do I think, like we want to try to understand each other, right? If our sibling is doing stuff that is really confusing, or our parent, or our child, or or another family member, those could be very difficult situations, and these concepts could at least maybe the person is in treatment, or maybe they're refusing treatment, who knows, but to the family member, um, we want to try to use these ideas to say, wow, this may help me to understand what's going on here. You know what I mean? If the clinician is confused, I can only imagine, the sort of
Sure.
the non-clinician is even more like, whoa, this feels strange,
Absolutely.
but you know what I mean? I wonder how you might speak to
Yeah.
how
So
could we, yeah, go ahead.
yeah, no, absolutely, and it's a great question and an important one. So two things came to my mind as you were talking about this and asking. Uh, our our job is actually in some way for as a clinician, it may be in the parent role. Okay, so this can benefit both of us, a parent and a provider. But the 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 reality is that a parent or a loved one or a sibling or a friend may not have this training and may not have this distance or neutrality that
For
a
sure.
someone who's a provider. So things become more challenging. Now, what I want to say is that to know how or to train in helping a family member, first you have to understand. Okay, so for example, an example comes to my mind. Uh, some studies have shown that pe people with borderline personality have a deficiency in a chemical that our brain makes called opioids, which are the same that when we take pain pills. There's a deficiency there.
Mm.
So they're in pain a lot. Okay. And the opiate that our brain makes helps with pain to go down.
Mhm.
So when we understand this, we can start to think that, let's say, for example, someone cuts their wrists. Okay. While we think that's painful, and we think that why would someone do this? For that person, when they cut, their body is releasing the chemical, the opioid chemical that they're deficient in. So there's
Mm.
some relief in there.
Mm.
And that's why a lot of people tell me that when they cut, the minute they cut, they get extreme sense of relief.
Mm.
Okay. So I'm bringing up this example because when we understand that some of these behaviors is a way that the patient uses to soothe themselves or the
I
person
see.
uses to soothe themselves,
I
that
see.
may make us less reactive.
Right, more in a sense compassionate or empath. Maybe
Absolutely.
we don't like the behavior, but at least we can kind of feel our way into, oh, I can see why they're doing it.
Absolutely. Absolutely. Now,
Mm.
another important thing that we should discuss is something, one of the defense mechanisms that people use. All of us use them, by the way. People even with who do not have a borderline personality diagnosis, we do this as well. Something called projective identification, which is one of the more powerful and more, I want to say, confusing defense mechanisms. So, to give you, let's say, an example, imagine a teenager with borderline personality traits.
Hmm.
Okay? If that person is feeling ashamed, unlovable, terrified, or maybe even terrified that her mother will give up on her, okay? That person may have difficulty saying that, partly because they're young, partly because of this borderline personality organization. So instead of saying it or talking about it, they could act distant or cold or irritable or rude or whatever it is.
Hmm.
And she may say, why do you even care? You're always disappointed in me. You're always disappointed in me anyway. Something like that. Okay. So let's say, to extend this example, the mother is trying to be supportive, and the mom starts feeling, okay, that's not fair. That's not a fair thing to say. Or they may start feeling guilty. I let my daughter down. I can do nothing good. I'm a terrible mother, so on and so forth. Or things can progress and they may even become angry. They can say, why is she accusing me of this? Or, you know what? Out of my house. Something along those lines. Okay. As you can see, I'm sure all of us can relate, and not just with people with borderline personality, with a mother, a spouse, a daughter, whatever it is.
Hmm.
So this right here, what I'm talking about is projective identification. So the daughter is unconsciously pushing her feelings of whatever, rejection, shame,
Sure.
onto the mom. Okay. And her behavior, acting distant and cold and rude, uh, causes the mother to also act cold, distant, aggressive, all those things. So it's a form of communication. The mom starts to feel like what the daughter feels. Okay, it's almost like a mirror. Okay, these emotions are now playing out in the relationship.
Yeah.
Okay, so the question is, and Anton or Dr. Bloom, how would you react to something like this if you had a daughter and this was happening?
Call Dr. Soubani. No, just kidding. Go ahead, Bill. What do you think?
I think it's important to take a step back and be aware of your own self, your own feelings, to center yourself in what you really felt at the time, and not be swayed by that type of interaction that really is not a true interaction between one person and another. It's almost as if they're acting out a scenario that expresses pent up feelings and may have nothing to do with actually a situation that's going on. So I think it's important for people to kind of be more self-aware.
Sure.
And I think that's what helps maybe people with borderline personalities kind of get a handle on relationships, is when they're able to be more self-aware in the moment,
Sure.
and understand what's going on. And that takes a while. That skill is not something that develops quickly. It
Absolutely.
requires a lot of skill and time to do that.
For sure.
It develops gradually.
And
think-
Anton, what would you say in that situation? Let's say that a parent asks you, like, okay, what do I say when she's doing this?
Well, I think to Bill's, like as Bill's saying, first of all, the parent, I would try to help them sort of think about, first sort of step back and think about their own reaction and how they feel. You know, a lot of what we learn as therapists is to sort of suspend action or reaction and say, okay, right now I'm with this other person, I'm feeling XYZ, and being curious about what are those feelings, why do I feel that way, how can I understand them? That kind of self-reflection, I think, is a good starting point. I also often talk to parents, just like as you're saying, Omar, about many of the things that people do that are problematic. They're kind of like nonverbal communications, right? They're things that they're communicating, but not in the most effective way. So we try to help parents say, okay, yeah, I know that really was painful and very difficult, you know, like bothered you a lot. If we could understand how the mom feels and her reaction, we could help her try to say to her daughter, okay, yeah, I can kind of tell that you're really upset and scared that maybe I want to do away with you, but this is not a helpful way of telling me. Like, if you're scared that I want to push you away, I don't, but I want to try to develop a relationship with you where we could talk about things, where you could tell me I'm scared right now and I'll reassure you. You know, those kind of, we learned a lot of those sort of emotional regulation communication skills, but they're very, it takes a lot of practice, I think, is the hard part. They're not in the moment. It could feel like, I don't know, I'm gonna overreact, something like that. So I think it's a
Yeah.
it's a
Yes. Oh, I'm sorry for interrupting.
No,
One
go
of
ahead.
one of the things that happens in a situation like that is that there's a breach in empathy. And that's exactly what happens, is that people then fail to really understand each other from an
sure.
emotional standpoint.
For sure.
And as a parent, the best skill that you can have, and it's not an easy one to develop in a hotbed situation like that, is to maintain empathy for your child and try and understand the underlying feeling that they're expressing without reacting to your own emotions at the time. It's not an easy skill, but I think that's, responding to a child like that is probably the best course of action that I can think of.
For sure.
Absolutely. The one thing I will kind of maybe add, and it's really more repeating what you both have said, is I would advise a parent or a friend or a sibling to say, to wonder to themselves, absolutely, Anton, is this feeling that I'm feeling, is this my feeling? Or am I being pulled into something that
Sure.
this person cannot express? Really, and to really kind of phrase the empathy portion of this is that, to think of it as a way that the feeling is so intense and so unbearable for this person that
Mm,
they're trying to offload it on me.
right.
Right.
Um,
Yeah.
so that's
Yeah, that's a really good. They don't have currently the capacity to sort of manage or regulate that feeling. So they sort of you're like a co-pilot to them for the moment. You're sort of co-regular trying to respond in a hopefully reasonable way. Which yeah, I think as we're saying is not easy to do, and I think a lot of times I find myself, it doesn't have to be with somebody with these kind of conditions necessarily, but many times as a therapist, in therapy, we talk about using feelings and thoughts as information, as a source of understanding, not as necessarily something that has to be acted on or is good or bad. Like to your point about alexithymia, therapy is sort of like, almost like, I don't want to say the opposite, but it's the goal is to move in the other direction from lexithymia and be able to name, label, understand. Even like the term psychology, I think is interesting because it's like the logic of the psyche. It's how to understand the emotional feelings and thoughts. That's what makes, I think, mental health such an interesting field. That there's a way to make sense of these difficulties and hopefully handle them in a way that's more reasonable, more not as destructive.
There's kind of an old-fashioned term that I think is applicable here, and that has to do with the therapist as a container.
Right, for sure.
And the therapist is the container for all these strong emotions that
Right.
the patient might express during the session. And they don't actually reflect those feelings back onto the patient as maybe someone in a personal relationship with the person might, but contain those feelings and then are able to respond to the person in an empathic way that could be soothing and comforting rather than stirring more feelings up. And
For sure.
um, it's a dance between two people, and
Sure.
somebody's got to be the leader, right? Somebody has to understand what's going on.
Uh, Omar, I was wondering if we could talk for a few minutes about, we're kind of just sort of in that direction, but the kind of hopeful aspect that you mentioned about treatment, about, this is a complex set of conditions and difficulties that has many different roots and all the things we're kind of talking about, the complexities. What about from a treatment point of view? And so to speak, is there a reason to be hopeful? Are there, can we try to think of, are these things, to what degree are they treatable? Are they treatable? What would it take? Just kind of based on
yeah.
your experience and what you see.
Yes. So first, I would say very broadly and very generally, yes, that there is hope for sure. And these things, like any illness with treatment, they get better. Okay. Now it has to be the right treatment at the right time
Sure.
in the right place. Okay. And it has to be, um, and we could talk a little bit more about that. But yes, the overwhelming majority of people with treatment do improve. Now, and I can maybe share this with the audience if there's any interest, but there's many clinical trials and reviews of different combinations of treatment,
Hmm.
and they all show improvement. Okay,
Okay.
so everything works.
Hmm.
Okay. There's a lot of determining factors. Okay, that need to be discussed, and mainly what I mean by this is that first, the psychiatric disorders that are getting in the way, for example, post-traumatic stress or generalized anxiety or obsessive compulsive, they need to be taken care of. They need to be adequately treated.
Hmm.
Okay, because those disorders cause the brain to be in such a state of inflammation, let's say, that it's very difficult for um, therapy to take hold.
I see.
That's the first thing. The second thing is substance use. Okay, substance use on mood disorders and especially and with borderline personality is a real anchor around those things, and
Hmm.
they really are very destructive. Okay, so those things must be looked at and addressed. as far as therapy,
Yeah,
uh, the Dr. Bloom's mention of a container.
sure.
There's I'm going to reference another older psychoanalyst, Winnicott. I think it's either David Winnicott, I think, who talked about a holding environment.
Right.
Okay, that is the key in all of this. Okay, when I was in residency training a few years back, not that long ago, I noticed that the um, patient that we would stay there 1 year and then we would move on. So
Right.
each year the patient would get a new psychiatrist.
Sure.
There were patients that have been at that clinic for about 45 years almost, since they were teenagers, and now they're in their 60s.
Sure.
Okay. So I always wondered to myself is that how painful it is to each year go through a new resident
Yeah.
and a new therapist uh, and to repeat this cycle. It's almost like an annual trauma that the patient
Sure.
goes through. Okay.
Sure.
And I would see personally people cry and be upset and get angry when the resident leaves. Okay. So why would someone do something like this? In my opinion, and if I were to read Winnicott, what he would say is that the attachment is actually more with the clinic than it is with the therapist.
Sure. To the institution, so to
The
speak.
institution, exactly. It
Yeah.
becomes a holding environment for the patient. And
For sure.
maybe we can do this as a little promo for Start My Wellness. It's really the setting and even the physical layout and the building that really helps hold the patient together. Okay. Um, and this holding environment can mean anything. In my, in my, if I were to make recommendations, a holding environment can be even your schedule throughout the day,
Yeah.
getting sleep, and with that goes like sleep behavior, diet, caffeine, positive social interactions, exercise, of course, being productive. All of these things help create a holding environment for the patient. And for all my practitioners on this podcast, that can also, you are a central part of that.
Right, because it's like a sort of a regulating function, right? You're helping to predictability. You could expect that the place will be the same. The appointment doesn't change too much. The person is available, right? That kind of consistency can help with the containing and the person's having a hard time regulating their own feelings and experience, so they're relying on this kind of external resources to regulate some things that they're not able to do.
Absolutely, absolutely. And in some way, I mean, we talked about losses
Hmm.
uh, like the idea of a holding environment is really, it came from the image of a mother holding her baby. Okay, that nurturing feel.
For
Well,
sure.
we've talked about in the beginning of this podcast about early trauma and early maybe disruptions, especially with the mother bond with the baby. Well, again, the holding environment fills those needs in a way. Okay.
Mhm.
It's dependable. It helps a person reactivate their growth. There's physical aspects to it. Um, all of these things are so important. And if there are any parents or loved ones here of someone struggling with this, and again, and I do have to say, a lot of our discussion can be applied to many other things besides borderline personality.
For sure.
And that's why this is such a great discussion and a great idea, because it's such a universal topic, and
Definitely.
extends to other things. So if I was a loved one, or if I were to give advice to a loved one, is to find a place where the person can be held together in that way. And sometimes, I will say, sometimes, if and especially if suicide becomes an issue, sometimes a holding environment does mean an inpatient unit.
Sure. For sure.
That is a tool that sometimes needs to be used. So do not be afraid to bring someone to a crisis center or to petition them if needed. Okay.
Yeah, actually, I mean, to that point, there's a question from the audience. I think this is from a mental health professional. Um, the question is, how do you assess suicide risk in somebody with this kind of borderline personality organization,
Yeah.
especially if the ideation, if their thoughts about suicide are chronic or fluctuating? You know what I mean? Like, let's say somebody has some of these conditions
Yeah.
and they're always thinking about suicide, but you don't know, are they going to act on it? Can they act on it? And, you know, what will happen? Not that there's of course more than one answer, but in your experience, how do you think about sort of the risks or the impulsivity to self-harm in that case?
Yeah, it's a great question. And this is again, it does not limit itself to borderline personality, and we could have 10 podcasts about this. But for the purposes of this, suicide risk uh, is done in two ways, in two maybe vectors, let's say. There's chronic risk, something that is called like static. These things do not change. Okay. And then there's things called dynamic
Okay,
factors or acute factors.
sure.
Now, things that don't change are things like someone's demographics. Okay, so their age, their race, their gender. Okay, those things don't change. So people who are, Caucasian men over 50 are at higher risk than
Mm,
others. Okay, so those things you have to take into consideration. Family history. So does this patient or person have a relative who has committed suicide? That raises the bar or raises the alarm bell. If that person has had past suicide attempts, okay, the more suicide is almost like it's like a diving board. It becomes easier and easier to
mm,
jump off of it the more you do it. So people will become more impulsive. Okay, so these things are chronic and these are static. These don't change.
yeah.
So that again, that will build a foundation. So if you know this about a person, that this person has these risk factors and they've tried serious stuff before, mentioning and discussion of suicide should be taken very, very seriously. And your threshold should be much lower.
Mm.
Flipping the script. Yeah, go ahead.
Well, so on the other hand, if somebody talks and thinks about suicide but doesn't have either as many of the demographic
Yeah,
factors or a history of hurting themselves, not that you shouldn't take them seriously, but it's somewhat, you can kind of tell by that history that's somewhat lower risk and it's more ideas and
absolutely.
feelings much more than maybe actions.
Absolutely. And that's when we think about acute factors.
Hmm.
So is this a situation where there was a recent loss of job? Okay, or recent loss of a house, or a
Right.
recent divorce. These things just happened, or the
Sure.
patient's dealing with them now. The more that you can stack up, the more risk there should be.
For sure.
Now, you know the patient more than I know the patient. Okay, so if you know that this person has this pattern,
Hmm.
okay, you also need to set limits with that person. Okay, and also to wonder and to be curious why they're saying it in the way they are, but also to make sure that they know that if this is something that is that you are bringing up, I have to take it very seriously, and I also have to protect myself, and that's very important for the patient to know that there are boundaries.
Yeah, for sure.
Okay, so if the topic of suicide is brought up and it's brought up frequently, then it should be addressed.
Um, it's such a rich topic that we're talking about. Bill, and we're kind of running short on time just for today, but first, Omar, I really appreciate it's so fun to talk with you because, you know, it's nice to kind of interact and in other professional settings, but here we're kind of talking about the specifics of how we work, how we think, the richness, both the kind of risk factors and the richness of how we can understand people and work to help them. So it's such a interesting conversation. So we really appreciate your time and your contribution. And of course, as you mentioned at the beginning, you're a practicing psychiatrist. I know you see many patients. So if people on this podcast, or people who hear it, I know that Wayne State Psychiatry could be a good option for them if they're looking for help. So we want to just appreciate your contribution. But any kind of Bill, any questions that maybe we're not getting to or that you might think of, just to kind of we have a few minutes here today that might give the audience kind of additional information or anything else to consider.
One of the things that I'm thinking about as we're talking is um, the idea of stigma as a
Mm,
way of preventing people maybe from seeking help or maybe forming an identity that actually works against them getting help and being kind of honest with the problems that they're having. I think, Dr. Soubani, earlier you had mentioned that there's reason to be hopeful that the treatments can be effective. You identify, the coexisting psychiatric conditions, you treat them, and then even psychotherapy. I mean, it could be seen as a maybe a longer term project. It's not the kind of short term succession kind of thing that maybe some other conditions are responding to, but there is hope, and it that sense of hope that things can get better, I think, is a really important part of
for sure.
providing treatment to people and letting them know that there's hope and that you're there to try and help them.
Definitely.
Absolutely.
Yeah, I think a lot of times people don't, when you're out kind of in the community, whether it's a professional and you're not sure, what kind of colleague to collaborate with or consult with, or as a person who's looking for help for themselves or family member, it could be hard because the things like, you could type some of this into ChatGPT and say, hey, do I have, borderline condition? And I think AI tools can be useful. We use them all the time for work, but I think what you're saying, both you, Bill, and Dr. Shabani, is that there's a richness of knowledge and information that's available. We don't understand these conditions 100% or 1,000%, but we have enough knowledge and information to offer hope and help, especially if the person is willing and able to kind of pursue help. You know what I mean? Like the person has to be able or in a place in their life where they can kind of pursue and hopefully get help over time. It's not these are not conditions that could be improved immediately, of course, as you're saying, Bill, but somebody who can kind of persist and have a good enough environment and a helpful enough professional, they can gradually make progress. They can make gains. They can make improvements. There is reason, and not just for the severe conditions, but kind of everyday challenges. I think that's a very important message that's not enough conveyed. You know what I mean? I think it's a very important point.
I would agree. I would agree.
Anything else for you, Omar? Anything, any other comments, kind of anything that we appreciate the questions I think are helpful. Your comments are great. Anything else that maybe you thought we could mention today?
Uh, I mean, I would, first of all, thank you for having me. I mean, this has been
For
a lot
sure.
of fun and it's been learning experience for me just as much as I've shared, some of my thoughts. I would say, I mean, two things. The first, if for anyone who's a provider or a doctor or psychologist or therapist, I would say I can't stress enough how important it is for your own therapy.
For sure. For sure.
And that will go into my next point is for parents. Sometimes it's actually addressing own conflicts and solidifying parts of your own personality that will help. Because in our brains, there's a part of our brains that has the part, it's called the amygdala. There's something called mirror neurons, and they mirror what they see. So
Sure.
if you're able, especially if you have someone who is like a young child or a relative or a friend who's especially in that fertile, a developmental stage that you brought up, Dr. Bloom, if they are able to mirror you and they see their mom, dad, husband, whatever it is, working on themselves, that may be really the key.
For sure.
And
Good
that's
point. Yeah.
has been my experience.
Yeah.
No, that's a really, I think that's also an important, empowering point because sometimes The more we work on ourselves, the more we're available, we can kind of take care of ourselves. That can also benefit relationships and benefit the people around us. So that's, yeah, we're not just powerless. We can kind of, the person can get help. We can kind of get help to sort of improve our own way of taking care of ourselves. Okay, well, I appreciate, the participants who joined us, Dr.
Yeah,
Soubani, thank
thank
you so
you.
much again,
Thank you
Dr.
all.
Bloom.
Learned a
A
lot.
lot of fun, and hopefully we'd love to have you back sometime, Omar. It's really great, and we'll kind of keep the conversation going. So thanks for joining us.
Thank you very much. Have a good day.
Thank
For
you.
sure.